What's going on, everyone? Welcome back to the Adam Nessim Show. Today, we have a guest that I'm really excited about. We have David Zetter, who is the founder and president of Zetter Healthcare. He has over 30 years of operational and healthcare experience, and many recognize David nationally for his presentations, his experience. He excels in revenue cycle management, credentialing and contracting, compliance, coding, and documentation. Seems like anything a private practice would need, he's your guy. So, David, thanks so much for coming on today.
Happy to be here, Adam. Thank you.
Yeah. So I'm super excited to talk to you almost just selfishly because I'm someone who is interested in starting a private practice when I get out of residency. Can you just talk a little bit more about your background, how you came to have this company and do exactly what you do? Because it seems like a unique company that offers a unique service to physicians.
Yeah. So, I mean, in my previous lives, I was an executive in hospitality or actually restaurant management, executive management. And I did that for about 20 years. After that amount of time, I just got tired of traveling 4 and 5 days a week. I literally went and worked for a gentleman that had a consulting firm that handled healthcare professionals, consulting and accounting firm. I came in, proceeded to learn everything that they were outsourcing, chart audits, HR, right. Credentialing, things of that nature. So I became an expert in all those areas. We started taking on all that work. And then after so many years, I left, basically took the consulting clients with me because the rest of the people in the firm didn't do any of that work. And we've been doing this since. So now I've been doing it, almost 25 years. We work in all 56 U.S. territories. At any point in time, we've always got at least about 10 to 30 startup practices going somewhere in the country. Wow. And we probably have 300 active clients that we bill on a monthly basis. And we probably contract and credential about 6,000 to 10,000 providers a year.
Wow.
And we do so much more than that too. So we've got about 11 people that work for the firm. And like I said, we work with clients all over the country, all kinds of things from compliance to HR issues, to contract negotiations, to employment agreements, entity and governance documentation, things of that nature.
Got it. Very, very interesting. It's cool to see because, you always hear, especially me going through med school and then residency, that private practice is dying or it's dead and everything's being bought up by these big mega health corporations. What have you seen as someone, clearly you have lots of clients that are seeking out your services. I have to imagine that there's still some sector of private practice. Do you see like the pendulum swinging back the other way, or it never died to begin with? Kind of what do you see in that realm?
Well, for those that have been in the healthcare industry a long time, this is all cyclical. This happened way back in the 90s when you had all the insurance companies buying up medical practices. Back then, they didn't know what they were doing. They still tend not to know what they're doing. When they buy a medical practice, they end up taking all the ancillary services out of the practice, and they force the patients to utilize the services in the health system or the hospital. And really, if you really took a look at it, you look at the financials of that practice, all those ancillary services are what's creating profit for that practice. So when you pull all those ancillary services out, now the practice doesn't make any money. Hence the reason why most practices acquired by a health system or hospital lose money. Gotcha. And then the hospital expects that they're going to make all that money in all those ancillary services. So they use the practices as a loss leader, and, all those referrals go back into the health system.
Got it.
Back in the 90s, because they were losing so much money, all those health systems and hospitals spit out those practices again and basically told the doctors, we're not going to employ you anymore. We're losing money. You've got to go set up your own practice again. So that's what happened. Well, we're doing it all over again now. So in the last 7, 8, 10 years, you've had a lot of health systems and hospitals buy up practices again. Well, now you've got a lot of employed physicians that are fed up. They don't have any autonomy. They have no decision making, and they're basically a cog in the wheel being told what to do, and they don't like it. So I've got an awful lot of new startups. I mean, probably 75% of the new startups are physicians that are coming out of residency or fellowship, and the other 25% are finally finally realizing employment is not good for me. I want out and I'm going to control my own destiny. So yeah, we've got a mix of people that are either starting up their own practice and coming out of employment, or they're starting up their own practice from fellowship or residency.
Got it. Do you see, actually two questions. First, when you say ancillary services, what are some examples of that?
So ancillary services can be things like imaging, bone density scanners, MRIs, just X-ray, things of that nature, labs,
right?
Anything that you would refer out services. So even if you were going to refer, maybe you're a primary care doc, and instead of referring a patient for spirometry to an allergist or something like that, maybe they're going to start doing spirometry in their own practice.
Got it. Yep.
Or adding other services like remote patient monitoring, transitional care management, chronic care management. I mean, all of these services add a lot of revenue to a practice. And it's really a no-brainer. So, even if you're an existing practice and you really want to find ways to add revenue, adding, remote patient monitoring, if you're an internist or even a family medicine doc with a lot of Medicare patients, you could literally add another $200,000 to $500,000 a year in just incremental revenue just by adding those services.
Wow. Yeah. And I'm sure that's something.
It's not going to take much work for the physician. Honestly, all you really need is staff to do most of that work, especially on remote patient monitoring. And you're going to increase. I mean, literally, we've got clients that are increasing it by $500,000 a year.
Wow. And what's remote patient monitoring?
Remote patient monitoring, people have talked about telehealth or telemedicine a lot in the last 2 years. Mm-hmm. Well, remote patient monitoring is part of what is called telehealth. Telehealth and telemedicine are not the same thing. Telemedicine is a face-to-face visit using audio video capabilities. So that's when a patient is sitting somewhere else and you're actually conducting an office visit with them over video.
Right.
Whereas telehealth is exchanging data over the internet or over, Wi-Fi, things of that nature. So you're collecting measurements and data from equipment that may be a CPAP machine or blood pressure monitoring, a Holter monitor, even spirometry or things of that nature. You can take measurements of a patient. You have to have 16 measurements in a month, a minimum of that, in order to build the RPM code. But it's an automatic payment to you for that patient just by taking measurements. And then if you have 20 minutes of conversation in that month with that patient, and it doesn't have to be the physician, it can be an MA, you get to bill an additional code that gets you additional money. So the physician doesn't have to do much of anything and can increase their top line revenue by up to $500,000.
Wow. Very interesting. And hopefully too, by monitoring the patients, I mean, now you're practicing more of preventative care and catching things when
that is the whole reason behind it. Absolutely.
And so will that, because of that preventative nature, will that get covered a lot, mainly by the patient's insurance already? Or
Medicare covers RPM services.
Okay.
And many payers do. RPM is relatively new in the last few years, but many payers are seeing the benefits of this because instead of having a patient come in to check their blood pressure and to get those readings, now you're able to do it and get those readings from them at their home with some equipment, and they just send those readings to you, and they don't have to leave their home. They don't have to leave work. It becomes an ideal patient access, and you can get information and communicate with that patient without them having to leave their home.
Got it. Wow. Yeah, that's awesome. And you just have a lot more data on your patients when they do come in as well.
Absolutely.
Got it. And then going back to, you were saying you work about 75% are new residents, fellows graduating, and then 25% are leaving practice. Do you see a lot of fellows that go right from fellowship into starting a private practice, or do a lot try to work for a hospital system or private practice for a couple of years and then go off and start their own?
Well, I can tell you this. The ones that I see, we get an awful lot of residents and fellows that are starting up their own private practice. But there are many more out there that are employed that, I get so many new clients on an annual basis that are doing startups. And as I said, I'm seeing about 75% coming out of school to do an independent practice and about 25% coming out of employment. I've seen that percentage rise over the last year or two, meaning that more and more employed physicians are coming out and starting to go back into private practice. So at least for me, I'm seeing more that are coming out of school and starting at private practice, but the percentage of those coming out of employment is increasing each year, especially when you start getting to the point where a physician's contract is coming to term.
Right.
And a lot of times either the hospital will release them, especially if they aren't meeting the RVU requirements that they have in their compensation package. So the hospitals will release them, and then the doctors are trying to figure out what they're going to do. Some of them have signed non-competes, which is really a bad situation for the physician.
Yeah.
But in almost all cases, there are ways to get your practice set up, but you really have to make sure that you don't have a non-compete because you don't want to be sued. And, those hospitals have a lot more resources than the independent physician does to fight that kind of thing.
Yeah, no, it makes a lot of sense. I just did a podcast with a lawyer who does contract reviews for that specific case. Do you see, though, even being released, those non-competes hold? Because I would imagine if you quit, they do, but even getting released, you're still not allowed to.
Well, you've got to, I've been doing this, like I said, a long time, almost 25 years. And each year you start seeing more and more regarding non-competes. Even this year, the Biden administration has said that they want to get rid of non-competes out of all employment contracts. Well, it's going to be somewhat hard for the federal government just to dictate, hey, no more non-competes.
Right.
But the fact is, if you've got a non-compete in most cases that has a radius on, the locations that you can work in that is more than like 15 miles, chances are you're going to have a hard time finding a judge or a court that's going to allow that to stand because they have to allow you to be able to earn a living. And if you've got to move out of state to earn a living, that's ridiculous.
Yep.
Most courts aren't going to accept that, and most judges won't either. So I don't see a lot of non-competes being enforced. The key there is the other party willing to sue you or to bring a case? And, what's the possibilities of you being able to defend yourself?
Yeah,
but a lot of times you can just go outside the radius and literally set up a practice a block outside that radius and you're good to go.
Right. That makes sense. So speaking of, let's say someone's going to do that. Someone comes to you and they're like, I want to start a practice, but I've been trained all these years I know medicine, but I don't know anything about business. What are some of like the first things that someone should be thinking about?
Well, one of the first things I do with a physician or a new client that comes on board with us is we schedule a call to go over a startup checklist and a timeline. And I use that timeline from about 2 to 3 years out and everything that needs to be done between now and the time you start seeing patients. So we try to review all that just so that they can understand what they can become, they can know what they don't know.
Right.
Because there's an awful lot that a provider who's a clinician that never did the business of medicine isn't going to know. They're not going to know all this stuff in order to start the practice up. So for instance, how many things they have to comply with to ensure that all staff and providers are compliant with all training and education that's required by state and federal law. Well, you've got to do annual OSHA training. You've got to do initial and annual HIPAA training. It's got to be ongoing and constant. You've got to be able to show your compliance all the time from the beginning through to the end. So it's all ongoing compliance you have to provide proof of. There are systems out there that allow you to do that, and they're relatively cost efficient, and they're not hard to keep up, and you don't have to do a lot of work. Mostly your staff does that. But those types of things. And then even understanding how to credential and contract. And then one of the biggest things I talk about is revenue cycle. I always get doctors that say, I'm going to hire a billing person. And I'm going to say, what do you know about billing? And there's a lot of silence on the other end of the phone. I said, right. How are you going to interview a billing person when you don't even know what they do? You don't know the metrics that measure a solid and successful billing person. So how are you ever going to hire a good billing person and know that you did?
Yeah.
Well, it's impossible. So you got to know the job and know what the expectations are and know what the metrics are in order to be able to hire somebody for a position. It's no different than a doctor saying, I'm going to go out and hire an office manager. Well, how the heck do you know that they know what they're doing? And how do you know what their job is?
Yeah.
Therein lies the problem.
Makes a lot of sense. I've heard horror stories of billing going awry in private practices and you're losing hundreds of thousands of dollars in revenue. And
that's your cash flow. It's your lifeblood. Credentialing and contracting is the very start of your revenue cycle process. And if you don't have your revenue cycle process nailed down, you will go out of business.
How frequent do you see that where private practices are either going out of business, or how long do you see a private practice until it's profitable?
Well, that all depends on, every practice is different, how many patients they're seeing, what their per patient collection rate is, what their overhead is. So it all depends on the practice and the makeup thereof in order to determine how much revenue you need and how much profit you need in order to be able to keep your doors open. So that's going to be different for everybody's situation. The key there is that you've got to make sure that you've got contracts done properly, credentialing is done properly, and you have somebody that knows all of that in order to do it properly. Then you've got to have a financial policy that every patient signs so that they sign off that they're financially responsible if their insurance doesn't cover the service. Then you want your patients to know exactly what your rules are. Most medical practices and healthcare facilities out there chase money.
Right.
They have reactive revenue cycle management. And let me explain a couple of those things. You send out statements to patients to collect on their accounts where they have an account balance. Okay, help me understand in what business you collect money after the fact.
Yeah.
There are none. So, every business wants money up front. So why do physicians always set up their business where they're chasing money? You're not successful that way. So you need to set up what I call proactive revenue cycle. So you have predictive cash flow, and you can always predict your cash flow if you know how many patients you're seeing, you know what your average patient collection rate is, and you can budget and predict everything that's going to happen in your business. And then on top of that, you can predict exactly which patients are going to pay you. No different than what I do. I recommend it for my clients. You maintain either a debit or credit card on file for every patient. It needs to be done properly, PCI compliant. So you can't just write down their credit card number and put it in a file cabinet.
Right.
But you do this properly. And then when the patient account, when their balance hits their account, your system, your merchant services will automatically bill that patient. Your staff doesn't have to do anything. And that money goes right into your bank account. Why have somebody that's in the back of the room, at back of the house at your practice, on a phone calling patients in the middle of the afternoon when you know they aren't home? And now they're leaving a message saying, hey, Mrs. Smith, we're calling about the balance on your account. We'd like to collect a payment from you. Well, again, you're trying to chase down that money. They aren't going to call you back. They ignore your statements. So chances of you collecting it are slim to none. So set up a process that guarantees that you're going to collect that money.
Yeah, no, that makes a lot of sense. Do you have, because I went to the dentist the other day. I thought the way I always like to, when I go into different practices, just kind of look at what they're doing. And before I even went to the back to do the cleaning or whatever it is, they were already like, this is what it's going to cost. Can we charge your card right now? And so I had paid before any service was even done. I know it gets a little bit difficult because when you don't always know, what service is that patient going to potentially need, but do you recommend to your practices, like, at least have them do the initial copay or whatever it might be for a standard visit before you even see the patient?
Always. The way it should work is that, my proactive revenue cycle, first of all, dentists from a business standpoint tend to be much smarter from a business standpoint than physicians, because dentists actually go through some business classes, whereas physicians, the last time they had a business class was in their undergraduate degree, and that's if they took any.
Yeah, barely. Yeah, probably not even.
So, you've got dentists that do things much differently, and most of that is because, think back, way back, most dentists never accepted insurance. That's only a recent thing in the past 10, 15, 20 years. So every dentist set up everything so that they would collect money up front. Every physician shouldn't be allowing any patient to come back into the exam room until they've collected the copay and whatever deductible the patient still has to meet. All of that should be verified up front prior to the patient even showing up for the visit. So you do insurance verification, eligibility of benefits. You'll know everything that you need to collect the minute that patient shows up. And then once they do show up, make sure that you have that credit card on file. That way, if a balance does hit their account, then you can automatically charge it. And then another proactive revenue cycle stance, instead of the patient coming in and checking in with check-in first, the first person they should see is somebody that I call a patient financial counselor. That person checks them in, gets their signature on a financial policy, sets up payment plans with the patient so that they get authorization to automatically bill the patient's debit or credit card should they have a balance on their account. And that patient would fill out that form, tell them how much they can bill every month until that balance is paid off. And then you never worry about any payment from that patient again. And part of your financial policy requires the patient maintain a valid debit or credit card at all times. Otherwise, you legally discharge. So like I said, if the patient visits them first, they can set up the payment plan, get the authorization form signed, find out how much the patient's willing to pay on a monthly basis. And that person gets all that nailed down before the patient ever goes back and sees the physician. They cover the financial policy with them. And then the patient walks out of there knowing exactly what the expectations of the practice are for them from a financial responsibility and from a compliance responsibility.
Got it. And is that someone's sole role in the company? Like that they're
yeah, normally when we set up that patient financial counselor position, that is their job. And I've got a handful of practices that actually went in that direction. Not every practice wants to set up everything that way, but
right.
The practices that do set all this up have very little AR that are over 60 days.
That's awesome.
Even MGMA, their metrics are anything over 90 days. If you have 10% or less of, AR in your aging buckets over 90 days, they think that's good. Well, I think 0% over 90 days is good.
Yeah, that sounds a lot better. I agree.
Yeah. That way you're collecting all your cash.
Mm-hmm. Got it. So if you're starting up a practice, what are all the positions that you think you should get right from the beginning? And also to pay those salaries, do you see physicians that are just starting out are taking out like a small business loan, raising capital, or how are a lot of people financing that?
Well, we help our clients with whatever they need. We're always determining, okay, are they independently wealthy? Do they have family that they're going to borrow from? How exactly are they going to pay for this? First thing is you got to determine, okay, what it's going to cost. Now, on average, a small practice with solo practitioner starting up, really doesn't matter the specialty unless you're going to be a high involved procedure specialty like a surgeon, or you're going to be some other specialty that's going to require a lot of ancillary equipment, things of that nature. Most practices can get started up if you're frugal. I'm not saying cheap, but you don't start up a new practice spending a ton of money.
Right.
You wait until your practice is solidified, and then you can get all the stuff that you really want, like mahogany doors and stuff like that. If that's what you want. But, most practices, you're going to need two loans. You're going to need a startup loan that is going to go, and you're going to use that money to spend on all the invoices for, maybe the down payment for the lease, for your equipment, for your furnishings, for supplies, to buy your computer equipment, things like that. So that's your startup loan. Mm-hmm. Normally, most practices for a solo practitioner, you can get all of that done for less than $100,000.
Oh, wow.
Then and some of it can be even less than that. Again, it all depends on each physician's situation. Mm-hmm. Then you're going to need what is called an operating line of credit, because once you open your doors, the bank doesn't allow you to use that opening loan for any operating expenses. Now you're operating, you've got to have a different type of money available to you. And that's called an operating line of credit. That's normally going to be somewhere in the neighborhood. I usually suggest $100,000 to $150,000.
Right.
It's left there in an account. Actually, the money's not in an account. It's just set there aside for you. And when you borrow against it, that's when you start paying the interest.
Right.
And then you can pay it off, and it's available for you maybe 10 or 15 years. And you just keep borrowing against it, paying it off back and forth as you need it to operate. And most people will utilize that in the first few months of every year because their cash flow is slower when you're trying to collect deductibles and things of that nature.
Got it. So someone opening a solo practice, though, do you see them starting to, from the beginning, hire an office manager, maybe someone like maybe even a medical assistant, the financial counselor, and start paying those salaries as well using that line of credit?
Well, depending on the situation, most solo physicians, all they really need is an MA or two. They don't need an office manager when you're that small.
Got it.
As long as either the MA has some knowledge or they're utilizing some kind of expert, such as myself, that's going to assist them in making sure things are done and coaching their staff or coaching the physician on what needs to be done, how to do payroll, how to make sure they're compliant and paying payroll taxes and things of that nature. They could hire an office manager, but an office manager is going to be more expensive, and it's good, you're going to have higher overhead doing something like that.
Right.
So it really depends on, okay, what the wherewithal is as far as what the practice is going to be doing as far as revenue. Again, that's all determined in a pro forma, doing a budget and really calculating out, okay, what's it going to cost you, how much revenue you're going to produce, and how many employees can you afford. In order to figure that out, you've got to do some kind of a pro forma so that you can figure out, okay, how many patients you're going to see, how much revenue you're going to have, what is it costing you for everything. So even when we go over our startup checklist, if somebody needs to borrow money, we're going to have to figure out, okay, how are we going to estimate revenue? Then we've got to figure out all their line item expenses on their P&L, and we want those to be as accurate as possible. So I even have them go out to a medical supply company, start documenting SKU numbers on what equipment, what furnishings, what supplies they want, how many, and total it all up. That way we know exactly what we're going to spend. And the same thing would be, hey, are you going to use laptops? Are you use PCs? Are you going to have a server? Is it going to be cloud-based? How much is all that going to cost? All of that goes into the pro forma so that we can determine exactly how much money it's going to take to get the practice started.
Yeah, no, it makes sense. Those, the EHRs, they can be expensive too.
Yes, they can.
Are there any ones that I know there's so many out there now. I was looking into them the other day just to see, are there any ones that you specifically like or see that works better for practice?
Well, no, and I respond to that question with this answer. It's almost impossible to tell anybody, hey, this is a good EHR. So Adam, when you're trained to do an encounter with a patient, you're going to do it different than me and different than 100 other physicians.
Right.
You may like to use macros. You may like to use freehand typing. You may like to dictate. You might, who knows how you want to do. So one, it all depends on the EHR. So first off, I always recommend you go after an EHR that has a lot of installations in your specialty. Then you want to find out what it was developed for. So for instance, NextGen was all built for orthopedics and OBGYN, yet now they claim they're for everybody.
Right.
Well, that's not exactly true. So you can't just say an EHR is one of the best out there. Everybody's different. Every EHR is proprietary. So do you want your people to go through a lot of point and clicks and a lot of screens to get to do something? Or do you want something that doesn't take as much in order to get something accomplished? Every EHR and PM system is different. You need everyone kicking the tires, including your billers, your schedulers, the physicians. That way everybody gets input and you get the best EHR and PM system, practice management system, that is best for your firm or your practice and best for everybody. So you weigh all the pros and cons. It takes a long time to make a good decision on an EHR so that you aren't one of the 75% out there that hate their EHR.
Right. And then are switching, and then that whole process is
and that just costs you massive amounts of money.
Yeah. Makes sense to do your due diligence earlier. And that's why working with someone like yourself who knows it all is, I'm sure, helpful for many physicians starting
and
a practice.
And spend the time to develop your templates well in advance.
Got it. Awesome. All right. I don't want to take up too much of your time. I really appreciate you coming on. This is definitely super, super valuable for all the listeners and anyone watching this. Just one last question, and then love to hear where people can find you. What would you say is like one of the biggest mistakes that you see from a physician who's trying to start up a practice?
The biggest mistake is that many physicians have certain expectations and they don't know the facts. Get the facts first before you assume something, because even nowadays, many people are asking, okay, how long does it take to get contracted and credentialed? Well, people used to say 90 days. Well, since March of 2020, that amount of time is doubled. So to get credentialed and contracted now is taking anywhere from 90 to 180 days because every payer has everyone working remotely. Nobody answers phones, and it's taking much longer to get things done. And there is literally no oversight for those workers. So they aren't working as hard as they used to.
Wow. So do you see people doing starting that process in fellowship, or is that even possible?
Well, you can't fellowship. You have to be out of residency first off, because no payer will credential you being a resident. Medicare will, but they're the only payer that will. So you have to be out of residency. But yes, even a fellow can get started sooner than later. It takes time to get that credentialing and contracting done. And let's face it, the day you open your doors and you want to see patients, you want to be able to schedule as many patients on that first day as possible. So you need contracts in place long before that day that you open your doors.
Right. Makes sense. So there you have it. Be proactive if you're going to start your practice. And wow, this was awesome. I really appreciate your time. Super helpful. If anyone that's watching this is going to start their own practice or is about to leave employment because they're unhappy with their working as an employed-based physician, where can people find you to learn more about your services?
They can find me at zetter.com, zetter.com, or even just Google opening up a new medical practice, and you'll find an article that I was interviewed. You'll find tons of stuff, or even just Google Zetter. You'll see I'm all over the place, so it's kind of hard to miss me.
Awesome. All right. Well, thanks so much.
Thank you, Adam.